But again, at the top, you don't have to know this information. I don't think so. And then I put in here like the bones are classified by composition and structure and shape. Yeah, you don't have to know this either, but I do think that it helps to know and just kind of help remember and refresh. So it basically is what it's saying it is. Oh, not my cousin calling me right in the middle of this. Let me go ahead and reshare my screen. Okay. So you have long, short, flat, irregular, sesamoid. I don't know how to say that properly, but basically it is exactly what it is saying, right? So if it's long, it's long. If it's short, it's short. If it's irregular, right? So again, you don't need to know it, but helpful to know. For fractures, I think Harding does ask a test question related to this, or she at least puts something about a fracture in here. So pathological fractures, that's exactly what it stands for. So we're talking about it, something has caused this to happen, like a condition, something pathophysiology. So osteoporosis, cancer, because that helps weaken and atrophies the bone. So it's not necessarily there's a force that's acting upon it, it's without a force. It's just it happens with time, it happened with a specific condition and with a specific pathophysiology behind it. For fatigue or stress fracture, that's exactly what it sounds like. It's a fatigue or stress fracture. So I used to be a flute player, in which a lot of musical instrument people who play instruments, they kind of end up getting like arthritis as they're older, just because like you're always moving your wrists and you're always like moving your fingers. But basically, some people also end up eventually having some atrophy of the bone, and because of all the strain and stress that's on there, eventually that could just cause you to be more susceptible to having a fracture. So this is just saying if you have excessive strain or stress on the bone. So even if like you're an athlete and you lift weights a lot, eventually that could also make you more susceptible to having a fracture. So for compression fractures, exactly what it says as well. So this is just if a force is applied to the actual bone, and that just happens to be most commonly seen on the vertebrae. And I just think about like old people, like usually like if they fall or something falls on top of them, that's usually going to end up hurting their spine the most. So for different shapes that contain different portions of osseous tissues. So basically there's different parts of the bone, right? So you have compact bone and then spongy bone. The spongy bone is the one that actually looks like a sponge, right? And I think you remember seeing like the picture in ANP. It's like small lattice-like pieces that are called trabeculae. You don't have to know that, but I just think it's helpful. But just think about spongy is the spongy part, and we're talking about the inside, so the interior part of the bone. Whereas the compact bone, it's exactly how you're looking at the bone exteriorly. It's kind of more rounded, it's dense, it's smooth. And it has passageways that serve as nerves, blood vessels, and lymphatic vessels. And I would just think about it, those are running along the exterior part, right? So what's on the inside is what's going to help form your RBCs, WBCs, and the rest of that stuff. So compact is on the outside, it's dense, it's smooth, and it has those passageways like the lymphatic vessels, your blood vessels, everything like that. For the spongy bone, that's going to be made up within your red marrow and then your yellow marrow. So red marrow is exactly what it's going to produce: red blood cells, white blood cells, platelets. And then yellow bone marrow, that's basically going to help store your fat cells. So in case a person's going through any type of like anorexia or they're losing a bunch of weight, basically that's where your fat is also stored as well. And just in case basically your red bone marrow isn't producing enough red blood cells or something's going on with that, it's your yellow marrow is going to help transform into red marrow so that it can then produce those RBCs, WBCs, and platelets in case there's any type of anemia or any type of condition going on. So again, don't need to know that. They won't ask you that type of question, but I do think it helps just to kind of know. So this you definitely do need to know. So bones contain living and non-living tissue in which they're composed of blood vessels, nerves, collagen, which is a protein in the connective tissue, and living cells. So within those living cells, you have two important ones that you definitely need to know. And I don't think that they'll ask you like question like which one is this? Maybe Justice will on like a quiz, but like in terms of Harding, I don't think she asks us this specific question, but she'll use these terms in her exam. So osteoblasts, these are cells that help build the bone. So it's kind of easy to remember because they both have B's, right? So B for builders, and then osteoclasts, which are cells that help crush the bone. So this is going to be C for crushers. So just remember B for builders, C for crushers. Okay, so you have osteoclasts that break down your bone. So what is in your bone? What's like the most important mineral that's in your bone? It's going to be calcium, right? So we'll talk about it in a second, but calcium and phosphorus have an inverse relationship. And when I was looking it up, just because I was like, why do they have an inverse relationship? One, because there's like kind of like a negative feedback system that goes on, that helps to kind of with those levels. But also I read that it helps with, you need to have an inverse relationship of both of them, because sometimes when you're having like, I think about like chemistry, when you're having both of them, some elements combined, you can create a new chemical. So it's kind of like that when apparently when like calcium and phosphorus are together in the digestive system, sometimes it can combine it, and it causes something, it creates something new, and that ends up irritating your digestive system more. So something about that, you don't need to know that, but they have an inverse relationship. So if you have osteoclasts breaking down your bone, and again you have calcium in your bone, you're going to end up having that calcium go into your blood, and now you have a higher calcium. In response to that, your phosphorus is going to be a little bit lower because your calcium is a little bit higher. So just remember, like, what do osteoclasts do? They help crush the bone, and as a result, they're going to release calcium into the blood because they're breaking down the bone, and that's where the calcium's at. So under that, it just says use and stress can cause osteoblasts. I don't think you need to know this. And then inactivity can increase osteoclasts. So I would just think about it like, I don't think she'll ask you this, but if you're like, oh, I don't get why that's the case. I would just think about it like sometimes when you're not moving, then they're going to crush down your bones because you're not moving, you're not getting up, you're not being active. So you're going to want to break down those bones. They're going to be crushing those bones down because you're not moving. And now you have higher calcium. And then with use and stress, with osteoblasts, because you're using and your body's in a stressful state, your osteoblasts are going to help to build up your bones because you're in a stressful state. Again, you don't need to know that. It's really just knowing osteoblasts are builders, osteoclasts are crushers. So for hormones, the most important ones you probably need to know are calcitonin and then parathyroid hormone. And we'll talk about this when we go into endocrine. A lot of this stuff kind of deals with the endocrine system and talking about like the thyroid, and then we're going to talk about calcium levels again. But you still, just as a precaution, make sure you kind of understand this information. So with estrogen, basically, I think we all know what estrogen is, but specifically in relation to musculoskeletal, it does help with the osteoclasts. So again, those are the crushers, and it makes them self-destruct. So basically, it makes them perform apoptosis. So during menopause, when you know that women are now having lower levels of estrogen, those osteoclasts are not being stopped anymore. So now you're going to have an increased risk of having more bone loss, just because, again, you're stopping that osteoclast with estrogen, and now you have less levels of that. So now it's not stopping that, which allows them to be more active. Another thing, calcitonin, it also inhibits activity of osteoclasts. So this just leads to lower calcium levels because, again, osteoclasts help crush down the bone. What's in the bone? Calcium. Calcium comes out. So if it's stopping osteoclasts from crushing down the bone, nothing's crushing the bone, no calcium coming out. Now you have lower levels of calcium. Okay, and because you have lower levels of calcium, remember I talked about we have an inverse relationship with phosphate. So now it's going to go ahead and increase that phosphorus as well. So now moving to the next one, thyroid stimulating hormone. This one also inhibits activity of osteoclasts. So it's the same exact thing almost as calcitonin. It, because of lower calcium levels, because the osteoclasts break that bone down, now they're not doing it anymore. Now you have low calcium levels in the blood. For parathyroid, this is the only one that's different. So for the rest of these, they're all kind of inhibiting osteoclasts, but or doing something to prevent osteoclasts from occurring because we don't like that they're crushing down our bone. Parathyroid specifically promotes activity and number of osteoblasts. So that's the only different thing with that. So just make sure you will know the difference between the rest of them. So just think about it like parathyroid is just osteoblasts, the rest of them are osteoclasts. And again, osteoclasts are technically bad, like we don't really want that. And then osteoblasts, like that's a good thing because they build it up. For growth hormone, it's exactly what it is. It's initiating the growth of the bone. So I would just think about it exactly what it is. So again, just to go over it, just to get into your guys' head, parathyroid, only the one talking about osteoblasts, and we want to go ahead and promote that. The rest of them want to go ahead and stop inhibiting and stopping that activity of the osteoclasts. And then growth hormone is the only one just talking about growth of the bone. Okay. For Age-related changes, they always ask questions like this. I don't feel like on an exam they would, but I think when I can't remember if it's second or third, but I think it might have been Harding. I don't know. I have some exam stuff that I wrote out after I took the exam. So when we get up to that exam, I'll come up with a Kahoot again, and then I'll put questions on there that are related. So with age-related changes with this, I feel like they're all self-explanatory, right? I think the only ones you really have to focus on are the ones that are increased, because you know that the rest are decreased. But just keep in mind too, like if it's a bad thing, like if we don't want that, then technically you're going to have that when you're older, right? So if there's going to be IM and subcutaneous fat when you're older, it's like, okay, well, that's obviously not a good thing. So it's going to be increased as you get older. So bone loss, that's not a good thing. So you're going to have increased bone loss as you get older. Postural tremors is one that you do kind of have to make sure you're paying attention to, just because as you start aging, and also because of even with like electrolyte levels, if they end up, especially when we're talking about ABGs coming up, you have to be noticing tremors, things like that. Same thing with vitamin D absorption. It's going to be decreased. And again, that just makes sense because everything's deteriorating, right, as you age. We're going to talk about that in endocrine, because basically vitamin D is also important for production of calcium. So it's going to be decreased with that. For gait changes, I'm trying to remember if she asked a question like this, but I think it can be like, just remember they're going to have decreased walking speed. They're not going to have bigger stride lengths. And that makes sense, right? They're not able to walk and take a bigger step. They're going to be shuffling almost, right? And then they're going to not have one leg movement. Like they can't hop on one foot, nothing like that. So again, everything's deteriorating. We we do want things to be good, but when you're answering a question, you're going to look at things that are bad. Okay, so in terms of diagnostics and stuff, so x-rays, I don't really think they ask any questions about this. I just think, again, it's helpful to know, and it kind of ties into when we're talking about bone cancer and everything. So x-rays, they help to evaluate bone density and structure. You're looking at the bone itself, fractures and bone growth. So like if they come to the ER, we can really quickly just do an x-ray, and then there you go. So for a CT, this is used to evaluate musculoskeletal trauma. It also shows other organs and bony structures that are going on. And so just remember, if they need consent, you need to get consent from them. And especially if there's IV contrast, we also want to make sure if they have any allergies to iodine or shellfish. And then additionally, metformin, which we know is like a diabetic medication we usually can be given, that could be nephrotoxic with the contrast. So you want to check if they're receiving that medication as well. Little things, and usually I would say around neuro, this is more around neuro. I don't know specifically why. I think it's because you talk about some stuff with MRIs, especially if they're a neuro patient. She starts asking more questions, at least for Harding. She started asking us more questions about like things to be aware of for diagnostics, like consents, the iodine, metformin, things like that. So as you get further along, just in case on a quiz or anything, just make sure you know that information. I feel like it's kind of more of just memorizing it. So just make sure you have that down. In terms of MRIs, this is another thing she'll talk about in neuro, but just to get into your head, yes, you still need that consent, and obviously you need to see if there's any metal in the body. So like if you go into an MRI room, usually there's a button where like they activate where it has the metal, and you don't want any metal in that room because of the actual machine. So if they have like a pacemaker, if they have any rods, especially when we're talking about musculoskeletal, because if they're receiving like any type of surgeries, like ORIFs, things like that. So open reduction, internal fixation. So you guys were able to go to the OR. You're able to see some of those surgeries. If they have metal in them, you need to know that, right? Also another thing with MRI, and she talks about this in neuro, this wasn't gonna say earlier, make sure that they have like earplugs, because it's a super loud machine. It doesn't really pertain to this, but just in case, I think it's helpful to start getting it in your guys' heads. So it shows more detailed images, determines more abnormal tissues, and this kind of pertains more to cancer, right? Because we can do an x-ray and we can do a CT, but specifically with an MRI, that's going to show us those different spots and everything like that. So this can again show necrosis, osteomyelitis, tumors, disc abnormalities, so basically everything, but it's just more detailed than the first two. So for a bone scan, this is specifically, I kind of went a little bit, I put in more information here because it's just kind of interesting, and also I think it kind of helps to understand what's the difference between a bone scan and then a bone density scan. So a bone scan, basically what it is, it's nuclear imaging to look for bones, diseases, infections, or trauma. So basically like what the rest are doing. But they give you an isotope injection. And so that's going to be absorbed into the bone. Through the bone scan, you're going to be able to see cold spots and then hot spots. Cold spots are basically showing that there's poor blood supply, whereas hot spots are showing that, okay, a large amount of the tracer is taking in. So this could be because of the healing fractures that are going on. Maybe there's a bone infection, maybe there's bone metabolism. So both of them are bad things. We don't want to see cold spots, we don't want to see hot spots. So they both can indicate bone cancer. So it's kind of like an MRI as well, like, or a PET scan. Like if you see hot spots on there, that's not a good thing for tumors. So specifically with bone scans, we're seeing where in that bone or what's going on with that bone. And then obviously with cold spots, we're worried about poor blood supply to that bone because that can cause necrosis and that can end up spreading further, right? So both of them bad. But basically it's just checking the bone supply in the bone of what's going on. And then again, you do need consent because again, we are giving an isotope injection. And that kind of just makes sense because if you're giving an injection, we need to consent to that, right? So bone density scan, the difference between that and a bone scan is this one's looking at the actual density. So what are the minerals and the content in that bone? Not necessarily just not the blood supply, but what is in that bone, right? And so this is checking usually for osteoporosis. So for an arthro, what this is just talking about, this is more related to joints. So this is the only thing that relates to joints. I would just think about it. This arthros are just related to joints. And so it's just looking at the interior surface of the joints, so all of those different things. And then again, it uses contrast. So again, we're going to need that consent. We're going to check for metformin because it's nephrotoxic. And you're going to then do blood tests. So for this, we're now talking about calcium and phosphates. Again, they're supposed to have an inverse relationship. And again, that can be tied to digestive things, whatever. You don't need to know that. But they both with bone cancer can be increased. So that's how you know something's going on with this patient because they're supposed to be having an inverse relationship in their labs, but now something's going on. So let's check into it because now they're both increased. So with calcium, again, they're increased with metastatic cancers because again, maybe those osteoclasts are breaking down more of those bones, and now you have an increase of calcium in the blood. For phosphates, again, it's just increased with bone tumors. So you're not there's something going on with your negative feedback system. Something's not going right there. And then for alkaline phosphatase, this is increasing with bone or liver damage. This was just memorizing for me for these ones. But again, like your phosphorus, it sounds like phosphatase. So, right, it's going to be increased. And then creatine kinase, this is also released from muscle breakdown. So that's going to be increased as well. And then that's also just inflammation markers as well. And then for uric acid, this has to do with gout. And you guys learned about gout in second semester. You don't really have to know what gout is, but again, that is a part of the musculoskeletal system. It helps weaken down your bones, especially around your joints. So then you can see either elevated levels there as well. But really the most important thing to know is your calcium and your phosphate are going to be high, and you want to watch out for that. So in terms of the like negative feedback system that I'm talking about, again, we'll talk about this in endocrine more. I don't think they want you to know too deep into it. But basically it starts off with, let's say, you have an increase in the calcium. So your thyroid gland is going to go ahead and release calcitonin. So calcitonin helps to inhibit those osteoclasts. So that's going to basically stop those osteoclasts from crushing down the bone. And then that's going to keep the calcium in the bone because they're not crushing down that bone. So now you have lower levels of calcium. And then eventually when you have lower levels of calcium, your thyroid gland is going to know that, hey, something's going on. We're getting too low on the calcium. So it's going to release parathyroid hormone. And so another thing, you could also test for parathyroid hormone, how much are they having, just to see maybe if there's something going on with their thyroid gland. But again, we'll talk about that in so they'll go ahead and release parathyroid hormone, and that's going to go ahead and more deal with osteoblasts, and that's going to go ahead and also prevent osteoclasts from happening. So it's going to end up raising those calcium levels in response. So just remember, inverse relationship, bone cancer, both increased. The last thing, needle biopsies. So these are just specific to tissues. It's exactly what it is for cancers. We want to get a biopsy, see what's going on. So you can get a biopsy of the bone marrow, or you can get a biopsy of the bone tissue itself. Okay, so again, I don't think they'll ask you super deep into that information, but if you just know it, I think it helps to know more on the exam. I don't feel, just because, again, like you're going to have multiple different chapters in the exam, I don't think they'll harp too much on musculoskeletal. There'll probably be a couple, but don't feel like there's going to be a bunch. I think the only things that we're going to talk about is like the osteosarcomas and all of that stuff. I think they'll ask a couple of questions, but they're pretty straightforward, like what is it type of questions, like what is it, what does this patient have if they're coming in with this. Just because I think the names are confusing and they know that those are tricky and confusing, so they want to make sure that you're knowing the difference between all of those. Okay, so different components of the H&P when we're getting an assessment done for a patient. Obviously, we want to know what was their history. We want to know their age. We want to see, the most important things we want to see their gait and their posture, right? Because we know they have some type of kyphosis going down. Their gait, we're having less one leg movement. We're having more a shuffled gait. We're not able to take as big of a stride. And they're not able to maintain their balance more. So I think these are all pretty self-explanatory. So again, I don't think you need to like harp on this too much, but basically I think I wrote this down because this might have been a question. So they should demonstrate an erect stance. So their feet are on the ground and then, their arms are usually swinging, but they're not swinging too much, right? And then their feet should be like base wide shoulder width apart. And then you should see a symmetrical arm swing from the placement as they're moving. So if they're walking, that's not like their hands are going all the way up here, and it's not like their hands aren't moving at all, because that means they're struggling to maintain some type of balance or to even continue walking or have a smooth gait. So they should be, just keep in mind, I feel like they ask specific things about that, so I'll try to put that on like the Kahoot, and I'll try to remember if they ask something like that. But keep in mind, we want everything to be normal. If even though we're talking about like arm movement, that still needs to be within a short amount of, not space, but it should be normal. It should be in ratio to how they're walking as well. Okay, so with bone cancer, with this, again, I don't feel like they asked a bunch of questions on the exam, but I know Justice's class, if you guys being quizzed over this, I feel like she would ask the differences between the different classifications. So bone cancer is more seen with children rather than adults. It's mostly seen in the arms and legs. That makes more sense, right? Because those are where your big, long bones are at. So patho and causes behind this, basically, it's unknown, but there is an osteosarcoma theory. So basically, your bone starts to grow a lot more. And what ends up happening is, as a result, the rest of your bones end up getting weaker because now you have more growth on this other side. And basically, this also means it can be triggered by an oncogenic agent. So when we talked about cancer, like at the very first beginning of the year, which it feels like the year's going by so fast, we were talking about carcinogens, right? So there could be, it's basically the same thing here. Remember, for risk factors, it's still going to be age, it's still going to be genetics, it's still going to be you're at risk of getting carcinogens. So there could be a certain type of thing going on, or an agent that kind of helps to proliferate cell growth and bone growth, which then ends up affecting the rest of your bones surrounding it, because that specific part has so much growth on it and the rest of them aren't able to be as strong as that certain part, so it's more relying on that part. The rest of them become weaker as a result. So it's exactly for the manifestations, it may be present at a tumor site, and there's just other signs of bone cancer. So I feel like all of these make sense, right? Like there's pain that's going to be worse with motion, and then if it's starting to get to the point where like even when they're at rest, it's still not, their pain is still there, it's not, we're giving them analgesics, it's still there, then something else is going on other than like arthritis, things like that. So with pain, yeah, it must result in a limp. You see swelling, you see redness, decreased range of motion, and then eventually you start seeing fractures because, again, because you have increased osteoblastic activity, so that's building up the bone because something's going on. And regardless, we don't want too much osteoblast, we don't want too much of that osteoclast to be broken down, to breaking down the bone more, so we have increased calcium. We want it to be normal and leveled out, right? So if there's too much osteoblastic activity, basically what can end up happening is you have that increased growth that I talked about 2 seconds ago, and because of that increased growth, the surrounding areas just become weaker as a result. So other signs of bone cancer: weakened bones, so that was mentioned earlier, joint swelling mentioned earlier, tenderness also mentioned earlier. So with the other bone signs for cancer, fatigue, fever, weight loss, anemia, those are just like general signs that you see of cancer, right? So just keep that in mind. Like you're still going to see your general signs of cancer, but that goes with any type of cancer. You're still going to see fevers, weight loss, anemia, they're tired. But specifically with bone cancers, it's exactly what it is. You're going to end up seeing like being at risk of having more fractures. They're going to be red. They're going to be swollen on those certain joints, on those certain bones, wherever it's at, wherever the tumor is located at. But I feel like it's all self-explanatory. That's why I'm like, it's not, it doesn't feel too bad. So this is the confusing part. I would recommend if you're not really understanding this, it's funny because so far in fourth, we haven't gotten to this information. So even I had to review it, just because some of the names, I'm like, you've got to be kidding me. Whoever came up with these names are ridiculous. But I would write it out. And so I usually have it clear for you guys, but I just kind of wanted to keep it highlighted just because I feel like to show you kind of how I did it whenever I'm studying this stuff. What I would do is like get a whiteboard and just write all of this stuff out exactly how you see it almost. So I would kind of just list it out like, okay, under this classification, you have 2 of these. Under this classification, you have 3 of these. And then I kind of would just list what they are. So if you're able to kind of just write it down, because you do get a piece of paper, or you should be allowed to get a piece of paper or like a whiteboard out during your exam, I would just write it out and be like, okay, these are all the different ones. So here it is. So it kind of, for me, it was kind of more of just memorizing, but also when you think about it, it does make sense and the different names match with what they are. So when we're talking about bone cancers, and this is just general, when we're talking about tumors and cancers, there's benign and then there's malignant, right? So benign are pretty good. Like they're not terrible. We probably still need to treat them and remove them, but it's not cancerous. It's not going to metastasize anywhere. It can still cause pain, but it's not going to kill you. So benign, non-cancerous tumors, they're usually discovered on an X-ray, right? Because we're able to see that there's something going on. We're maybe having more bone growth, maybe something, we're having some bone loss somewhere. But you don't necessarily need to get an MRI, right? You don't need to get a bone scan, maybe, just because we're not necessarily needing to look at certain hotspots, anything like that. But they can still choose to do that, but you don't need the most like PET scans, MRIs, like how you do with cancer. Sometimes it's just like, let's check it on an X-ray, hey, and then let's remove it. So causes are unknown, but it can cause and it can arise for different types of tissues. So basically, it has what benign tumors are classified in within bone tumors. It's slow growing lesions. They are well circumcised, and that's a good thing, right? And when we're talking about the cancer characteristics at the beginning during immune, remember they're able to just kind of go anywhere. They're just doing their own thing. They would be not well circumcised. They would be mal-circumcised. Whereas with this one, like, okay, they're benign. Like it's okay. We can kind of see where they're at and we can kind of probably remove them a lot more easier. And then because you're able to see that, and because they're a little bit easier to remove, you can show and actually see that pattern within an X-ray, and that specific outline is called a sclerotic rim. So on the specific part, if you can see like the outside part of it where it's a little bit white, that's the sclerotic rim that they're talking about. So when they see it on an X-ray, it's like, okay, we know that something's going on, but it's super defined. It's well circumcised, right? Like it's not just like going all the way out. It's like it has a fine border and you can see that. So for the classifications, so again, I would try to just write it out, try to see if you can like list it all out. And for me, it was like with the immunity stuff during immune, a lot of that stuff can get confusing. So I would just recommend, because there's so many of them, sometimes it is just kind of like you need to be able to write it out. And go about it that way. So for classifications, chondrogenic, I don't know if I'm saying that right, but chondrogenic, that has to do with cartilage, right? And that stands for C, right? And then osteogenic is talking about the bone. So osteo, we know that's related to the bone, whereas chondro, that's going to be talking about the cartilage. And I feel like that's super easy to remember because it's C for C. And then obviously we know that osteo is related to the bone. So within the first one, chondrogenic, so cartilage, we're talking about osteochondroma. So it's difficult because it has osteo at the beginning as well, but this is still pertaining to bone and cartilage. That's why it's under chondrogenic. So this is, again, we're talking about benign, we're not talking about malignant. So it's non-cancerous bone growth. So something's just going on, you have a little bit of bone growth. So if a patient were to be coming in and the doctor tells them that they're having osteochondroma, obviously that sounds terrifying. And you have that basically they're like, well, do I have cancer? And it's like, but it's benign, like it's very treatable. and it's the most common, and usually it's seen in the femur and the tibia, and usually it can happen during childhood, but we just know at the beginning, remember it says most people who get bone cancer are not adults, it's going to be children. So yeah, it's going to be non-cancerous bone growth, and what it's just saying is that you're having extra bone growth. So the picture for that is just right over here. So obviously to the right side, you can see that, and it doesn't look good. It doesn't look pleasant, and you're still going to have pain, and you're still going to probably have a little bit of swollenness, but you won't necessarily maybe see like fever, anemia, like all of those cancer signs because it's benign, but you're going to have specific pain, things that are related to this joint and this area, if that makes sense. So they're more bone related, whereas when we're talking about malignant, you're also going to be seeing cancer signs because now it's with bone cancers, you can still have metastasis if it's malignant. So that's kind of what it looks like. You're just having more growth, but it still includes, I think the reason why it's saying osteochondroma is because not only are we talking about a joint area, but it's also still on the bone. So when we're talking about chondroma, so now we've elevated to chondroma. So this is growth of the cartilage itself. So basically you end up with lesions, and those are commonly in your hands, feet, ribs, sternum, and spine. So with the osteochondroma, you're having growth of your bone and your joints as well. Whereas with chondroma, now you're specifically talking about growth on your joints. So if you see in this picture, that's the lesions that they're talking about. So if she were to show you an image, you'd be able to point this up as, well, it's benign, right? And it goes under the cartilage, so it's going to be chondrogenic, and then specifically it's chondroma because we're just talking about the cartilage. We're not talking about growth of the bone and the cartilage. We're talking about the cartilage right here. And that makes sense because if we're looking at the joints where they're going off of, so let me try to get my pencil out. Okay, so right there, let me make it thinner. So right there, right here, here, but they're all in the same type of regions, right? Like where you're kind of flexing your hands a little bit. So like if obviously from my fingers, right, we all have it. There are certain parts that bend, right? Here, your cartilages. So those are going to have those lesions on them. So that's how you can tell the difference between chondroma, because we're talking about specifically the cartilage, whereas with osteochondroma, we're talking about like we're seeing on an x-ray and you see a little bit of bone growth and you might be able to feel it maybe, but it's on their joints and it's the bone as well. And usually that has to do more in that specific location, right? Femurs and tibia, so longer bones, and usually it's at the end of them. Whereas with chondroma, we're just seeing that cartilage, we're just seeing that growth there, and that's usually dealing with your hands, your feet, and that's usually the type of thing that they're going to give you. They're not really going to give you like a spine or like a sternum and be like, hey, I don't even think she put pictures on there, but just so that you know the differences between those. So now osteogenic, when we're talking about the bone. Okay, so osteo means bone, right? So that makes sense. Chondrogenic, we're talking about cartilage there. So now we've moved up. So again, we're still talking about benign. So osteoma, again, whoever came up with these names are terrible, but distinguished by pink granular appearance. So that is something that I feel like they mentioned. And again, I'll check on the exam stuff, but just kind of keep in mind, this is what we're talking, like, there are certain things for each condition that they point out, and especially with these, because there's so many different ones, just kind of keep in mind, like, well, let me point out the ones that are a lot different. So pinkish granular appearance, and this results again in proliferation of osteoblasts. So we're building up that bone now. So we're not talking about cartilage growth. Now we're talking about just the bone. And so basically you're having osteoblasts building up that bone. And again, as a result, the other bones surrounding it end up getting weaker. So now you're having some pain there. So most common in your femur and tibia, which is exactly the same thing as the top as well, but now we're talking about the bone. So I feel like that's kind of easier to remember because it's like the first, I kind of sometimes when I'm taking an exam, I'll literally picture my study guide sometimes and be like, okay, this is where it was at. So both of them had to deal with femur and tibias. And then for the picture there, if you can see, like over here, we're having some growth and everything there. I should have done a better circle. Okay, and then for osteoblastoma, this is just a giant osteoid osteoma. So basically, you had an osteoma, you're having pink granular appearance, and now you're having kind of more growth going on with that bone. And then now you're having even more of that. So it's literally, I would just think about it like it's literally saying blast. So just think about it. You have your cartilage, that's basically talking about bone and cartilage growth. You have chondroma, just growth of cartilage. And now you're having osteogenic, that's just your bone, that's going to grow your bone. And then this is going to grow your bone even more. So on that side, this is what osteoblastoma looks like. So now you're having this dark part of your bone. I don't know if I can erase it, but on the highlighted section. But basically you can see that it's starting to grow a little bit more, because this one's not as much, but now you're having growth here, which is a lot more. So again, I would write it out if you're getting these confused, just because they are different names, but I do feel like if it's, at least if you can tell the difference between chondromas and osteogenics and osteoblastomas, that the difference between the names, and you'll be able to kind of figure it out. Then you have underneath, which is still talking about osteogenic, we're talking about the bone, you have giant cell tumors, which is an aggressive and extensive lesion. So eventually it's going to grow to the point where now you have a lesion and it's protruding out. So that's how you know it's giant. So it's gone from osteoblastoma to now giant cell tumor. And that does sound malignant. So obviously if a patient comes in, you're going to tell them they have a giant cell tumor, probably need to preference like, hey, it's still benign. Like the name does sound terrible, and it is aggressive and it is extensive, and that's because you're still dealing with the pain, and you're still dealing, and that still needs to be removed. And the problem with that is, because of that inflammation and because of how cancer works, it's not necessarily that benign can become malignant, but because of what happens and that there's inflammation of the bone and now the weaker part of your bones, you're still at risk of getting cancer and it becoming, and to produce malignant tumors on your bones somewhere else, because there's still activity going on that's abnormal. So for fibrogenic, this is exactly what it's saying. So this is the other option that we have. So we have chondrogenic, osteogenic, and now we're talking about fibrogenic. It's exactly what it is. It's just fibrous tissue. And I don't think that they'll ask you that. But this is just most commonly seen in children. For this whole bone cancer thing, it's all, we're going to be talking about children. So this is just discussing children. And the reason for that is because keep in mind, they're not as older. They have smaller bones. It's a shorter person, right? So for treatment of benign tumors, yeah, this may include to remove it, because obviously with like a giant cell tumor, if it's starting to pop out and it's starting to become a lesion and that growth has been so big, for the bone, you're going to have to remove that because they're still having pain. And then especially as they get older, that's not going to help them walk better. It's not going to help them be able to get up. And you don't want anybody to have to go through that type of pain, right? So this may include getting medication like analgesics, NSAIDs, inflammation, for that type of inflammation that's going on, or just to get surgery to remove it. So you might have to tell the patient that, yes, you will be getting surgery, but again, it's not like it's going to kill you. We can just remove it because we don't want you to be dealing with the signs and symptoms more of. And so again, if there also are patients who necessarily don't want to receive drug therapy, or they're like, it's not that big of a deal, it's benign, you can still do pain relief measures, which with the heat and the cold. So remember, like, heat kind of brings more inflammation in because of all of that blood flow that's not going, because you're vasodilating those vessels, whereas with coldness, like if I were to put an ice pack, you're kind of constricting that more. So just keep in mind, like for certain types of patients, like you're going to give heat and cold. Yes. So now for malignant, so sarcomas are bad, is how I would think about it. So the rest of them, it's like, okay, osteochondroma, chondroma. Now we're talking about osteogenic, osteoblastoma doesn't sound that great. But it's like, at least they don't have sarcoma, right? If there's an S in there, if there's a sarcoma, that's bad. So now we're talking about malignant bone tumors. So again, it's unknown. They don't really know what's going on. So there's a primary source and a secondary source. So primary is just like genetically, like 10 to 30-year-olds end up getting it. Whereas secondary source, it basically originates from one tissue to another. So malignant meaning that it is cancerous. That could mean that this cancer has been caused somewhere else and now you have bone cancer, or vice versa, like you have bone cancer, now it's metastasizing, because that's what malignant is saying, malignant for metastasizing, yeah. So M for M, right? So again, this would occur for secondary sources at an older age, because now it's kind of, as you get older, you end up being more at risk of being able to be having more cancer, just because your immune function is down and they're not able to see those malignant cells as quickly. So again, I don't think you have to know that, but just know that malignant is not good, because we have metastasis going on. So there are primary tumor classifications in this. There's osteosarcoma. This is the most common type of primary malignant bone tumor. And specifically, you will need to know this, Ewing's sarcoma. This is most commonly in children. We see it all the time with this bone cancer specifically. We're talking about the most risk patients are going to be children. So Ewing sarcoma still has sarcoma in it. Not a good thing. You know it's malignant. But specifically, I think the question that they asked is like, where is this located or something? So it occurs in the pelvis. So in that region. So this is what is going on. So you can see that the bone looks like what happened to the pelvis. We know that the pelvis should be dense, like the exterior, right? Should be that compact bone is what I'm talking about on the outside. That should be dense. It should be smooth. Now it's not, right? So it's literally atrophied. It's like something's going on, and obviously, that does not look good, and they're not going to be able to walk good. They're not going to be able to be mobile, honestly. So I would just go ahead and know that that is bad. Like we do not want sarcoma, and Ewing sarcoma is definitely the most malignant and most common that you see. So for chondrosarcoma, so again, it has chondro, so we're talking about cartilage, right? So this is basically, now we're talking about malignant tumors that are in the cartilage, right? So now those lesions, because again, we're talking about the cartilage, which is more prevalent in your joints, which can be like in your hands and your feet. Now those lesions are becoming so big to the point where they are destroying your bone, and they're calcifying. So they're breaking everything down. So that's kind of a picture of that, like they're breaking down those joints. Because in the other picture, like you have lesions, it's definitely not a good thing, but it's not breaking down your bone. You're definitely not having a good time, but now we're talking about it's more serious and it's actually affecting your bones, and you're going to have more of those signs and symptoms of cancer. And then fibrosarcoma from fibrous tissue, right? So it's going to start growing that tissue a little bit more, because when we're looking at the non-malignant, we're still talking about fibrous tissue and it's growing, but now we're growing to the point where that cancerous growth and connective tissue is going to build it up so much. So that's like what you see right there. And I think this is a baby's hand, right? So again, most commonly seen in children. So yeah, so basically, malignant is everything that we talked about with the benign, but now we're talking about they're cancerous and they're bad, and they're basically the signs and symptoms that they had, like the lesions on the cartilages and on your joints. That's going to be even more, and that's going to be to the point where it's now breaking down your bone and it's calcifying your joints and everything and making them stiffer. For osteosarcoma, just know that the only difference is like we're still talking about the bone, but specifically we talk about Ewing sarcoma because that's deadly. It is common, and it is in that pelvic region where you see it a lot in children. So that's the only thing with that I feel like they're going to mention is Ewing sarcoma, but just make sure you understand the differences between that. So then there's metastatic bone disease. And so bone metastasis occurs when cancer cells spread from the original site to the bone. And that's what metastasis is, right? Like they start spreading around because again, cancer doesn't care where it goes. We talked about that in the immune lecture. So primary tumors include prostate, thyroid, lung, kidney, and breast. So they talked about this, and you most likely will need to know this on an exam or on a quiz. So an acronym for that is particular tumors love killing bones. So particular being prostate, tumors being thyroid, love being lungs, killing being kidneys, and then bones for breasts, right? So those cancers just happen to be the most cancers that are linked to metastasizing into different parts, including to the bone. So it most commonly for bone cancers, most commonly is affecting your vertebrae, your pelvis, and that was what Ewing sarcoma, and then femur, which we saw with long bones at the ends of joints, things like that, and then your ribs as well. So you do need to know that acronym. I definitely would know that. For complications, again, like I feel like this is pretty self-explanatory, like pain and swelling, right? Because you have that growth that's going on now, the weaker part of your bones. And now with malignant, you're now having so much growth to the point where your joints are getting stiffer, your bones are getting stiffer, you can't walk anymore, your pelvis is atrophying. So that makes sense there. Weakened bones that lead to fractures, same thing what I just talked about. And then the biggest complication is that it can spread to other places, right? And you don't want that to spread because obviously if we're talking about, cancer on your ribs, what's that close to? Your lungs. So you have bones all throughout your body. So if you end up having a patient who had bone cancer and now they're like short of breath, you want to consider maybe there's some type of metastasis going on and be like, hey, doctor, I don't know, we should probably check in on the patient. So other complications, and this is probably the most important thing, an amputation, right? And it makes sense because we want to remove that tumor. And so that's why when it's benign, it has that sclerotic rim, so we're able to just remove it. But if it's malignant, you're not able to kind of see that rim anymore. It's not well circumcised, it's just going wherever, and there's bones throughout your entire body. So we want to stop that spread from happening. And what's the easiest way we can do that if it's become to that point is to probably do amputation and remove that part. And they do that anyways, even if it's on bones, right? We've seen people who have cancers in their legs, they end up getting their legs removed, things like that. So for open amputation, that's kind of going to look more like a guillotine style where it's kind of just cut off, right? And then a closed amputation more looks like a flap that is removed. So complications from an amputation. Well, obviously, if we're cutting out a part of them, and they're going to be at risk of having an infection, they're going to have delayed healing, chronic stump pain and phantom libs sensation. So I think about it when I think about like veterans. Sometimes when they've been, going through traumatic experiences, a lot of them come back with PTSD, but a lot of them come back with only one leg, with maybe they don't have arms anymore. So sometimes they end up having phantom limb pain. So even though they don't have that limb anymore, they still feel the pain of that, and they still have the sensation that it's there. And sometimes it can be a mental thing as well, but that's something that you want to know, and that's something that they will most likely ask you on as well on an exam or on a quiz, just because like, is it still possible for them to feel something, and how are you going to respond to that patient? Are you going to tell them that it's normal? Yes, like you're going to tell them, yes, this is normal that you feel that. This is something called phantom lib sensation or lib pain, and that's totally normal. Like, let's help treat that. What can we do to make you feel more comfortable? And then contractures as well is another complication from that. So I feel like those are pretty self-explanatory, because again, amputation, you're literally cutting off their extremity. So now talking about treatment. So again, if it's benign, you can just give them analgesics. Yes, they can go to surgery to remove it, and they probably should, just because it can still grow. You can give them NSAIDs, you can give them heat, cold therapy. So analgesics and NSAIDs for pain. Surgical, obviously we want to remove it. So we can remove that sclerotic rim. We see that we're able to remove it, and any other healthy bone that's surrounding it. Or you end up having to get an amputation if it's become so malignant. It's starting to metastasize. For radiation, this includes, we talked about this with cancer, brachytherapy, which is internal radiation, external radiation as well. So primary bone tumors use radiation to destroy and reduce size of the tumor, and then you can follow up with chemotherapy and surgery. So when we're talking about chemotherapy, we're talking about neoadjuvant and adjuvant therapy. So you can either choose to do it before, or you can choose to do it after. So A for after, remember that. So yeah, that can just end up helping to stop that metastasis in case it comes back. Because again, it's kind of like with HIV, remember, just because you're free of cancer, that doesn't mean you're not able to get cancer again. You're not cured. Sometimes you still have to go, and you're in like remission, you still have to go back to get chemotherapy after, just to make sure we kill off the rest of those cancer cells. You don't need to know the chemotherapeutic agents. I feel like they never asked us about that. So I feel like if you want to look at it, you can, but you don't really need to know that. For this, I feel like Harding asked this on an exam, like, what is the goal when we're talking about caring for a patient who has bone cancer? The most important thing is to understand that the goal is to destroy and remove the tumor, right? Like, even if it's benign, we still want to remove it because that's still causing them pain. So we want to destroy and remove it. And also pain control is the goal of the treatment. So just make sure you know those two things. Pain control is the goal of the treatment. And then the treatment goal is to destroy and remove the tumor. So both of those things are very important. And then chemotherapy is another alternative treatment. Obviously, if it's malignant, then most likely we'll have to get chemotherapy. And then surgical management on bone cancers focuses on the cancerous mass and limb salvation. So we want to also prevent amputation from happening, right? So if we're able to just remove that mass, even a malignant patient who has malignant bone cancer, that would be great, instead of having to remove a certain part of their limb. So yeah, just make sure you're knowing those two things. So destroy, remove tumor, pain control for sure. Okay, so I think that's pretty much it. Try not to harp too much on this stuff, because I feel like it's a little self-explanatory, but I would just say that, like with ABGs and everything for your exam, that's kind of more of what they're gonna focus on. They might ask a couple of these questions. Like I can see them asking like kind of what's the most primary tumors that you see. So that acronym is going to be important. amputation for sure, and like what are some complications from that, so like infection, and then the different classifications of those. Yeah, like they won't really ask you about diagnostics or anything, so that's pretty much it for that. So I'm going to go ahead and move on to ABGs and the stuff that you guys have to know. I think we'll probably get out of here a little bit early, so I'll try to see if I can make this a little bit quicker. So in terms of ABG, so now I'm talking to Harding's class because Justice's class, I don't think you guys have to know this, but not yet anyways. Um, so the way that ABG's interpretation works out, so they're going to give you an ABG set. Harding, you definitely will see it on her quiz. I think she asked us like two different questions on the quiz of like, what is this interpretation? Like, is it metabolic acidosis, alkalosis? She's not going to give you partially compensated because she knows you haven't learned that yet. So don't worry about that. I will sort of explain it here. But again, if you feel like you're not really understanding that information yet and you just only want to learn the uncompensated, like metabolic acidosis, all the things you know, then just ignore what I'm going to say later. So you have your respiratory system and your renal system that's in charge and control of your acid-base balance. Those are the most important systems, right? So your kidneys, your lungs. So your lungs are in charge of CO2. So CO2 can either be held onto. So if I'm hypoventilating, meaning I'm not excreting all of that CO2 because I'm not breathing, because CO2 comes out, right? For gas exchange, we need that CO2. It's a waste product. We need it to come out. So if I'm breathing out, all that CO2 is not coming out. If I'm not breathing, so if I'm hypoventilating, if you were to give me an opioid, right? What does that do? That decreases my respiration rate. So that means I'm not breathing. So if I'm not breathing, none of that CO2 is coming out. So now I'm retaining all that CO2, right? So that's basically how it works with the respiratory system. For the kidneys, they do two things. They have hydrogen, and hydrogen is an acid. You don't really need to know this, but I do feel like it's helpful, especially when you get into fourth, because at least Mandiola has us answer ABG questions on every single exam. Or at least I think she will because she does that with EKGs. But hydrogen is an acid. So your kidneys help with excreting hydrogen out, but really what it's in charge of is bicarb. So bicarb is a base, it's alkalotic. So it helps either excrete it or secrete it, or sustain it and keep it in there. So again, like to the side, so your respiratory system is in charge of CO2, and that's an acid, and that can either retain or excrete by your respiration rate. And either if like I'm breathing out, now I'm getting rid of the CO2, I'm not breathing out, so I'm keeping it all in. So that's in charge of there. Your kidneys are in charge of really bicarb, which is a base, and they can help retain that or they can help excrete it, right? But also they help with hydrogen, which is an acid, and they also can help to excrete that as well. But usually I would say with hydrogen, they're just kind of excreting it, not really necessarily retaining it, but really it's talking about bicarb and CO2. So with acidotic symptoms, and I have it under renal right here, but I should have put it like where it's just, I'm just talking about broad. But even with like respiratory acidosis, you're still going to be having CNS depression symptoms. So what that is, it's like coma, death, things that are like low. Whereas with like alkalosis symptoms, regardless if it's metabolic or respiratory, it's going to be kind of more of hyperactivity. Like you're going to see twitches, tremors, things like that. So that's how I would just think about like acidosis. I would, in my head, I feel like it should be the opposite, but it makes sense. Like acidosis, you're going to have lower, like I would say, like they're going to be low signs and symptoms, whereas alkalotic's going to be higher, like hyper signs and symptoms. So for ABG analysis, you don't need to know SaO2, PaO2. As you get into fourth, you do need to know that a little bit, but they'll explain it, and it's really not that difficult. For BE, you don't need to know that either. I feel like they talk about it, but like you don't need to know it. And Harding might put that on like a question, like for interpretation, but just ignore it. Like you don't really need to know that. For pH, obviously we need to know that because that tells us what our acid-base balance is at for our whole body. And then for CO2, that tells us how our respiratory system's doing. And then that tells us if we're in an alkalotic acidotic state, but in terms of respiratory. And then obviously with bicarb, you definitely need to know that. So know the normal values, right? I think you guys know that. So 7.35 to 7.45, CO2, 35 to 45, which is nice because it's basically the same thing. And then you just have bicarb, which is 22 to 26. So just remember 35 to 45 for the first two, 22 to 26 for the last one, which is bicarb. So definitely need to know that. Okay. So I just wrote down a couple of things. I'm not going to go through all this information because we'll talk about that when we go through ABGs. But what she's going to need to have you guys know, at least for your quiz. So the different signs and symptoms you'll see and the causes for metabolics, acidosis, alkalosis, all of these things. You need to know the signs and symptoms and you need to know the causes. But if I'm going to be honest, it's not going to be like you have to know every single one. It's going to be that you're going to need to know like one or two different ones. And she just gives you multiple choice answers and you're just going to have to pick which one is which. And it was only like 2 questions, but she just said like make sure you know all of them. Just in case, because she could always change that, right? So for us, I think the question she asked was for metabolic acidosis, like a patient who comes in with metabolic acidosis, what sign and symptoms are you most likely to see associated with this interpretation? So with metabolic acidosis, we're talking about the pH being low. So if a person is in an acidotic state, the pH is going to be low, regardless if it's we're talking about metabolic respiratory, it's going to be that the pH is low. So it's going to be below 7.35, which we have. When we're talking about metabolic, again, we're not talking about compensating or anything like that yet. If we're talking about metabolic, what's going to be out of range? It's going to be HCO3. And then if you're thinking like, how do I know if it's going to be low or high? Well, again, we remember that bicarb is a base. So if I'm in an acidotic state and a base is for alkalosis, I'm going to have decrease of the base, which further makes me have an acidotic state. And then your PCO2 is just going to be within normal limits. So that's how you know, hey, something's going on. So if this was like, this would be like what? Let's do like 37. So that's in a normal range. So you know that that is more pertaining to metabolic. That's what's causing it to be your pH to be an acidotic state. So the one big thing that you see with this is DKA, right? And I would just think about like DKA, ketoacidosis, right? And usually like we're not really talking about like your respiratory system. We're talking about like your pancreas isn't producing enough insulin, things like that. Now you're super hyperglycemic. So you're going to see Kussmaul's respirations with DKA. If you don't know what that is, what it is, it's basically deep and rapid respiration. So when a person's in DKA, you're going to see them like breathing in deep, like because they're trying to get all of that CO2 in and then out. And then it's going to be rapid because they're trying to compensate in that type of way. So again, with the signs and symptoms, we're talking about acidosis, which means we're going to talk about signs and symptoms that are technically like lower, like we're talking about like diarrhea, coma, death, headaches, things like that. So she might ask this because I feel like I remember her talking about diarrhea and vomiting for a quick second on the quiz. For diarrhea, remember you're letting go of a base, right? So you have base and now you're having diarrhea, you're letting go of all of that base. So now you're in acidotic state. I think the way that sometimes people get it confused is because I think a lot of people think about it, and I think I got this wrong in second semester when they asked this question, like, is diarrhea acidosis or alkalosis? Well, first off, the easy way to memorize this is we're talking about metabolic acidosis, right? So diarrhea, acidosis, that can help you remember that. But the reason why is because I think sometimes people get it switched because you're thinking about it in like a compensation way. Like you think that if a patient's in alkalosis where they have a lot of base, they want to get rid of all of that base by diarrheaing out. But no, that's not what it's saying. It's saying that what happens is that because you're getting rid of all of that base, you're in an acidotic state. So your body, it's not that it's wanting to be in an acidotic state, but it is in an acidotic state. So it's going to have diarrhea because you're in an acidotic state and it's trying to get rid of all of that base because it just cares about acid right now. So that's why you're having diarrhea with that. Whereas with vomiting for metabolic alkalosis, you're having, again, like if you're vomiting, it's coming out this way, right? So usually when you're vomiting, I hate vomiting. Like, by the way, like I haven't vomited since I was like 10. I refuse to. So what ended up happening is I think recently I actually threw up a while ago because I got a really bad migraine. But I prevent everything to do it because I hate that my throat stings afterwards. And that's because all of the acid in your stomach, right? We remember talking about that with different barriers. You have acid in your stomach. And so that can help with different pathogens coming in. It goes back up, it goes to your throat, and it comes back out, right? Now you can feel all the acid in your throat because there's acid in there. So it has acid in it. And if I'm getting rid of all of that acid, now my body's in an alkalotic state. So that's why it's with that. And then if I'm suctioning, things like that, I'm still getting rid of all of this acid. So we have a loss of a barrier in that way. So your body's in an alkalotic state. So that's the difference with that. But anyways, going back to the main point, Kussmaul respirations are deep, rapid respirations and things that you're going to see with DKA. Again, this is acidotic state that we're talking about with metabolic acidosis. So it's going to be in a state where you're more of seeing like lower levels of like you're going to see like, I'm trying to word this, like I guess like comas, death, like things like that. But really the one thing that she said, I think, is Kussmaul's respirations, just because this is mostly associated with DKA. For metabolic alkalosis, again, for this one, this is where you're seeing more of muscle twitching. So you're having kind of some hyperactivity going on when we're talking about alkalosis states, right? So signs and symptoms, your respiration is going to be slow and shallow. And like that's kind of a compensation method. But again, like I'm not really going to harp on that right now because we'll talk about that going forward. But like hyperactive reflexes, tetany, and that could also be attributed to electrolyte levels, but like dysrhythmias. So we're all talking about like hyperactivity stuff with metabolic alkalosis. So that's what you'll see for that. And then in terms of the interpretation, right? So alkalosis, meaning that it's going to be above for the pH. So it's going to be above 7.45, which we have. And so we're talking about metabolic. So that means the bicarb is going to be different, not the CO2. So the bicarb, again, how do we know if it's going to be high or low with alkalotic or acidosis? But remember, an alkalosis state means you have more base. HCO3 is a base. So if I'm in an alkalotic state, it's going to be increased. If I'm in an acidotic state, because HCO3 is a base, it's going to be decreased. And then because you guys aren't talking about compensation yet, all you have to worry about is the CO2 also within normal limits? It is. Okay, cool. So this one's going to be metabolic alkalosis. So for respiratory acidosis, basically again, you're going to see like CNS depression signs. And this one's going to be more kind of relating to like breathing, but specifically with metabolic acidosis, even though we're talking about like a kidney, like this is a kidney problem, you still see Kussmaul's respirations because the kidneys and what's going on with DKA is causing your respirations to be different with the Kussmaul's, right? But specifically, just remember, Kussmaul's is with metabolic, even though we're talking technically it's like a respiratory thing, but that's because it's doing a compensation method. But basically, with respiratory acidosis, you're going to see breathlessness, restlessness, lethargy, disorientations. You can also still see tremors, but I would just kind of, again, more relate this to, I don't think she asked us about this, but you're going to have like hypoventilation with this because again, remember like acidosis meaning that we're going to be one, the 7.35, it's going to be lower than that because that's an acidotic state. Okay, so we have that. Okay, we don't even care about bicarb. That's going to be within normal limits. And then we know that CO2 is an acid. And if we're in an acid state and we're talking about CO2, okay, well, it should be higher than 45 because it's an acid and that's what we have. So what that means for my patient would be hypoventilating, right? That means that their respiration rate would be lower. So if I'm not breathing, I'm not letting any of that CO2 come out, right? So that means all that CO2 is staying within my body. So remember that, like you're gonna have hypoventilation with that. Okay. And then with respiratory alkalosis, this is the most common imbalance. I don't think you need to know that. This is hyperventilation. So again, this is more of an alkalotic state. You're having more of like a hyperactive things going on. But specifically with this, what you're going to see and is what she mentioned was oral paresthesia and hand cramping. So that does kind of seem a little bit more like hyperactivity thing. So that's why I think it kind of ties in with that. But you're going to see hyperventilation, so she might ask that as well. So the reason why is because, again, if I'm not breathing, so if I'm hypoventilating, I'm keeping all that CO2. So that means if I have higher CO2, I'm in an acidotic state. Whereas if I am in an alkalosis state, that means I am getting rid of all that CO2. So what does that mean I'm breathing like? I'm breathing like because now I'm getting rid of all that CO2 and it's all coming out. So all that CO2 was just in me is now coming out. So you're going to be hyperventilating. So that means, again, we're talking about an alkalotic state. So the pH should be above. So we have that. Do not worry about bicarb because that's going to be normal. And then for your CO2, that's going to be decreased because remember, CO2 is an acid and we're in an alkalotic state. So that means now that this would be low. And that means that you would be hyperventilating because you're getting rid of all that CO2 and it's not being retained in. So, like in fourth, like when we're talking about, we start talking about vents, you guys don't need to know anything about vents whatsoever. But like for an example on your vents, I think you guys know what that is, right? Like they help a patient breathe. So essentially, they can also affect and you can change the person's respiration rate. So if I have a patient on a vent who's in respiratory alkalosis and they're hyperventilating on the vent, I'm probably going to decrease their respiration rate, right? Because I want them to retain that CO2. So, like a thing that you can do is give them a paper bag, right? Because if they're breathing out, even though they're breathing out the CO2 in the paper bag, that CO2 is still staying in the bag. And so when they inhale it, they're inhaling back in that bag, they're gonna get all that CO2 back. So that's why you give them a paper bag. But again, just know that respiratory alkalosis, oral paresthesia, hand cramping, so hyperactivity, respiratory acidosis, you're going to be hypoventilating, metabolic alkalosis, again, you're going to see that muscle twitching, talking about hyperactivity, and then metabolic acidosis, you're specifically seeing Kussmaul's respirations with DKA. I feel like that's what she pointed out for us, so I hope that is similar to what she points out for you guys. So for fully compensated, all that stuff, don't worry about that. You don't need to know that yet. So for this one, she does talk about I'm trying to remember. I think that's what I wrote down. Okay, she talked about osmotic pressure and hydrostatic pressure. Ugh, I hate all of these different terms because I feel like they get so confusing. But when we're talking about osmosis, we're talking about water. Okay, water for osmosis specifically is going from a low concentration to a high concentration. So I feel like that makes sense because that's what we've always been telling ourselves, like low to high concentration. With diffusion and filtration, it's technically going from a place of positive pressure to lower to negative pressure. And the reason why is because with diffusion, I kind of think about it like your respiratory system. And again, we'll talk about this in a couple of weeks when we go through respiratory. But when you're inhaling and exhaling, you go through different pressures throughout your body, right? With your environment. So that's how we essentially get air to come in and out of our lungs is the pressure that's in our lungs and the pressure that's in the environment. So sometimes you have, we'll talk about it. I'm not trying to go too deep into it. Sometimes when you're breathing in, you have a certain amount of pressure. So that allows the environment and the air to come into your lungs. And then obviously when you're breathing out, you have more pressure coming out. So you're able to breathe that air out. So I would just think about it kind of like respiratory. You're going from a place of high pressure to a place of low pressure. Because again, think about it like if you have too much pressure, like in your lungs, and if you're not none of that air is coming out, you're eventually going to be building up your lungs to the point where they're going to burst. So eventually that positive pressure in your lungs has to be able to come out and it has to go from a place of positive to negative pressure. So that's with that. I would just think about it. I relate it to respiratory because that's just how I think about it. But really, it's just going to be osmosis. It's going low to high. Active transport, I don't think you really have to know that. But so specifically, she had mentioned this one thing, and I was like, what is she talking about? But I think this is in the book. So she talks about in the question, I believe it was colloid osmotic pressure, and she was talking about albumin. So albumin helps with fluid balance, and it's specifically produced by the liver. So it helps bring in some of that. It helps with edema essentially because it helps bring in some of that interstitial fluid to the intervascular space and in that intravascular space to the interstitial fluid. So it sucks that fluid in. So it's great for third spacing, right? So remember we talked about this last time. I don't think last time, but we talked about it when we went through immune. You have your extracellular space and then you have your intracellular space. So which one has more body water composition? Like which one is more? Like which one has more of your body weight? And it's going to be the intracellular. And so the reason why is even though it seems like your extracellular space contains the interstitial space, so that's like around your cells, right? So it's going to be all around your cells. The difference is that when you're talking about in the cells still need fluid, right? They still need fluid themselves, but you have millions on millions of cells. So the amount of cells that you have versus like the fluid outside of them, your cells are still gonna win. So your cells, so in the cell, usually that's going to be more of your body weight rather than extracellular fluid. So that intravascular space, that interstitial space, that's only 20% of your total body weight. So just know that intracellular, you have more of your body weight there. And then for the colloid osmotic pressure, so yeah, albumin helps to suck that fluid in. So specifically, colloid means protein. So you don't feel like you have to know this like super in depth. I just think she asked this question. I kind of just memorized it a little bit. So colloid, which means a protein. So if we're going from a place of low concentration to a place of high concentration for solutes in water, at least for osmosis, right? Protein is big, right? And it's high concentrated. So when we're talking about colloid osmotic pressure, we also are talking about oncotic pressure. That's basically the same name. It's the pressure that pulls water into the circulatory system due to the presence of proteins, which is colloid, in the plasma. So it opposes hydrostatic pressure. And so hydrostatic pressure is a part of the filtration. And so that basically also helps with fluid balance as well, but it does the opposite because it's going from a place of high concentration to low concentration. So with oncotic pressure, colloid osmotic pressure, what it does is it opposes hydrostatic pressure, right? So it pushes the fluid out of the blood cells. So oncotic pressure draws fluid into the capillaries from the interstitial spaces, and it helps counterbalance the hydrostatic pressure. So really what it does, it helps to prevent edema from happening. And what I think she just pointed out, I can't remember what the question is, but I know she talked about this. And I think it was like, what are you going to see with the liver patient regarding like colloid osmotic pressure? So that helps bring and prevent edema. And so with the liver patient, because they're not producing that albumin, you're probably going to see some types of edema. So I think she asked like what signs and symptoms. So obviously with the liver failure patient, I know you guys have learned jaundice, right? Like that's probably the biggest thing that you're going to see with the liver patient. But also you can see ascites, which is talking about fluid. And I think it might have just been like edema or something like that. But you're gonna see abnormalities in fluid because also just remember like osmosis is in charge of like your fluid, your water balance, and so is hydrostatic pressure. But the difference is that we're talking about with osmotic pressure, we're talking about the colloid, which is albumin, basically, is what she's referring to. So that might seem confusing, but I would just go ahead and remember like if you see colloid osmotic pressure, just remember osmosis is going from a place of low concentration to a place of high concentration. And usually she's talking about albumin. And so with the liver failure patient, you're going to probably see signs and symptoms of like fluid overload a little bit, or not necessarily fluid overload, but like inflammation, edema, third spacing, basically a little bit. So with hydrostatic pressure, what that is, it's so with osmotic pressure or oncotic pressure, so technically colloid osmotic pressure, we're talking about proteins with that. We were talking about like proteins. With hydrostatic pressure, we're talking about filtration. We're talking about this is just like pressure. This is just gravity. Like there isn't proteins involved, there isn't solutes or particles involved. It's just like the pressure, it's just like the gravity. But hydrostatic pressure is in charge for those nutrients and oxygen to get to the tissues. So it helps basically get the fluids from the intravascular space into your interstitial space so it can go to the tissues. Whereas with osmotic pressure, it's going from the interstitial space to your like your intravascular system as well. So again, if that's confusing, just remember hydrostatic pressures with filtration, osmosis is with colloid osmotic pressure. So I feel like that one's pretty easy to remember. And then with osmotic pressure, we're talking about a protein. We're talking about usually albumin, which has to do with the liver, in which you might see inflammation, ascites, things like that. So try not to get too confused on that. If you have to look into it a little bit more, I would use probably some ChatGPT to explain that, and I'll see if I can find a video, but I would take a time to read it just so you can go through that information. Another thing that you do kind of, I think she asked us, was some labs that you need to evaluate. So your body weight, right? That can tell you if the patient's in fluid volume overload, right? Osmolality, right? BUN creatinine has to do with your kidney function. Are they excreting anything? Are they excreting too much? But specifically, I think she had mentioned your H and H. So can your H and H be low if you're dehydrated? Yes, that is right. So we're still talking about like perfusion. We're still talking about things like that. If you're not properly hydrated, your cells aren't properly hydrated. That includes your red blood cells as well. So you can see a decrease in your H&H. So right here, I won't go through this, but I kind of looked this up and got this information more. So if you're still confused on like the oncotic pressure and all that stuff, just kind of read this through, and hopefully that can end up helping out with that. The one thing that you will have to know, I'm not going to go through it, just because it can take a little bit of time, but it's not that difficult, I feel like, because we've seen it like 50,000 times. But trust me, like, don't feel bad, because I feel like every single time I see it, I'm like, I totally forgot that this is a part of it, like certain steps. But know the raw system, because I think she asked about this as well, because you're talking about fluid balance, you're talking about your kidneys, and obviously when you're talking about ABGs, you're talking about your kidneys as well. So just go through this. This was from Farm, because I really liked how Shay made this. And then at the top, it has like there's a tutorial.com that goes through this information, I think. And so I think it helps explain that very well as well. But just make sure you're going through this and you understand the process of this information, just because she might ask you a step about that on a quiz, because I believe she did for us. Okay, and then right here, I won't go through this either, but I did have like scenarios to go through. I guess I can go through like one really quickly. So for scenario one, this is basically how she's going to give it to you on a quiz and how they will give it to you on an exam. On an exam, though, we're going to start adding in partially compensated and stuff. So if you're confused, don't listen to me right now what I'm going to say about partial compensation. It might seem confusing. And I remember in second semester, I was like, oh, I'm not going to worry about partial and that type of stuff until we get to it. Reasonably so. But basically, to kind of explain, what they're talking about with compensation is basically, you guys have seen so far, one of them is out of range, the pH is out of range, obviously, and then the other one's normal. Now you're going to be adding in both of them are abnormal, and one of them, and the pH is going to be whatever. So how do you know which one is which? Well, you can look at the pH, and then also, like, we'll talk about it like next week when you guys go through this information. But basically, the other system is going to be compensating. So one of them is an acid, and then one of them is in charge of a base, right? Your kidneys are in charge of the base, and then your respiratory system is in, so your lungs are in charge of CO2. So we know that CO2 is an acid, and we know that the kidneys are a base, right? So when we're talking about like compensation, basically, if I have too much base, so I'm in an alkalotic state, so my pH would be super high, right? If I'm in an alkalotic state, my lungs are going to go ahead and increase CO2, because I'm in an alkalotic state and CO2 is an acid, right? So then it can even out my pH level. So when we're talking about like compensation, we're going to be talking about the other side is going to be compensating to level out your pH. And that makes sense, right? Because one of them's an acid, one of them's a base. And if you have too much acid, well, then maybe the kidneys will retain more of that bicarb. So think about it for a second. But if you're not getting that, that's okay. We'll talk about it. Just know that for right now, for your quiz, one of them is going to be abnormal and the other one is not. So if she does that too, that'd be really mean. So I don't think she'll do that. And I don't think she did for us. It was just like, this one's metabolic acidosis. But anyways, okay. So if you're getting confused, like in terms of interpreting, one, you can have a paper or like a whiteboard on the exam, I think. For a quiz, I think some people got it out, but you might just have to remind her for a second. Okay, so what is going on? Okay. So I would just recommend writing out, I have to write really weird right now because of my pen being terrible. So I would just recommend to write out if you feel like you're still not getting it. Oh, it added in the text. There you go. If you're still not getting it, maybe you have to write the values out. So 7.35, sorry for my handwriting, 7.45, that's the pH. And then we know that CO2 is going to be 35 to 45. And then bicarb is 22 to 26. And that's just pure memorization, right? So I don't want to show you the answer, even though you probably already saw it. So the pH, it's 7.35. Does that mean I'm acidotic or alkalotic? Acidotic, right? Because it's lower. So we know that that's an acid. Okay, and then I also asked ChatGPT to do this, and I just realized I have to ask ChatGPT to make me new questions because I think it's trying to give you like some partial compensated stuff. So to make this, okay, but actually, I don't think it did. Okay, good. Okay, so in terms of bicarb, so bicarb should be 22 to 26. So it's 18. Okay, so we know that that is definitely abnormal. Okay. And then with CO2, we know that the values are supposed to be 35 to 45. It's 40. So that's normal. So we know that this is going to be metabolic because we're talking about bicarb, and then we know that it's an acidotic state, right? So that's how you look at it. So literally just look at what's abnormal and then what the other one is normal, and it'll tell you if it's respiratory or metabolic. That's the fastest way to do it. Additionally, why would bicarb be low? Well, remember HCO3 is a base, right? And if we're in an acidotic state right now, it's not going to be high because a base would mean alkalotic. It's going to be low because you're in an acidotic state. So that's why HCO3 is going to be below the 22. So I hope that makes sense. So it should be metabolic acidosis, but to kind of explain, the low pH indicates an acid state. The low bicarb confirms that it's metabolic acidosis. One, because CO2 is not within normal within normal limits, and then the HCO3, something's going on with your kidneys, so we know that it's metabolic. You know, it's a renal issue, so that's metabolic acidosis. So you can just look at what's abnormal, and that'll tell you metabolic or respiratory, and then you can look at the pH, and that will tell you acidosis or alkalosis. If you want to further confirm, you just have to think about it, right? Okay, well, HCO3 is a base, and if we're in an acidotic state, then that means we would have less base because we're acidotic, not alkalotic. If we were in alkalotic state, we would be having a higher base, right? So think about it like that, in that type of way. But yeah, and you guys can go through the rest of these. I just have one for each one, so just make sure you're checking with that. So when we're talking about, again, if you're not wanting to know the compensation stuff, don't listen to me. But I feel like some people, if you're already ahead of the game and you just like kind of want a little bit of a heads up before she teaches the lecture, so this would probably be like maybe like 48. Let's do that. So basically, when we're talking about partially compensated, it's like, okay, well, you still know that they're in metabolic acidosis, right? Because we talked about that. You have lower bicarb and your pH is low. So these are both in an acid state technically. But now CO2 is above normal limits. Actually, this should be lower than that. This would be like 30. Because remember, for a partially compensated state, when we're talking about compensation, we're going to mean that your respiratory system, because we're talking about metabolic acidosis here, your respiratory system would then compensate to either increase the acid or decrease the acid because you're in an acidotic or alkalotic state. So if we know that this one right here is a metabolic acidosis, basically, because CO2 is also an acid and we want the range to be between 35 and 45, basically what you're going to learn in this next upcoming week is that when you're seeing a different value, so you're seeing that it's 30, yeah, so this would be partially compensated metabolic acidosis because that means your respiratory system is going to go ahead and get rid of CO2 in your body. So you're going to have a lower CO2 because remember CO2 is an acid, and if CO2 was high, it's going to further worsen the acidotic state that the patient is in. So as a result, your respiratory system is going to go ahead and get rid of all of the CO2. So it's going to make CO2 lower. And that's how you know, okay, this patient's body is working good because even though they're in a metabolic acidotic state, their respiratory system is now starting to get out of range in compensation of what's going on with their kidneys. So as a result, they're going to get rid of that CO2 because if we increase CO2 and now we have no base, you're in such an acidotic state. But if you're in an acidotic state because your kidneys aren't getting retaining all of that base, which is the bicarb, right? They're going to go ahead and your CO2 is going to go ahead and decrease as well. So you're going to go, your respiratory system, you technically would be hyperventilating more, right? We're getting rid of that CO2. Now you take my blood gas levels, you see that my CO2 is at 30, but you know that, hey, like, you know what? That's fine because she's getting to a point where they're trying to fix the pH. So really, when we're talking about compensation, we're trying to fix that pH level, the overall level. So we are worried about bicarb. We are worried about CO2 levels for sure, but we also want to range to see like where their pH is at. So again, don't listen to me if you feel like you don't need to know that yet. Harding will explain it. Justice will explain it very good as well. But when we're talking about compensation, we're just talking about the other system is going to either be increasing or decreasing to further help with the acid state or to help with the alkalotic state. So it's not going to worsen the state, right? But they're not going to give you that because that'd be very complicated, and that's kind of more fourth semester stuff. And even in fourth semester, we'll talk about it hopefully, and we'll talk about like different types there, but it's really not difficult as well once you get this stuff. It's really just saying, okay, you're seeing this other one out of range. Okay, what is it doing? What is it helping with? That's really it. So just know for today, or at least for this time for your quiz, just worry what's within normal range, what's not. So that's, I'll send you guys these forms right here. I'll send you guys this one. You guys have access to this, the study guide. So just take a look at that. I'll give you guys this page, the raw system. I'll give you guys the practice thing. And then the last very thing to end this on, you will need to know the fluids, that your IV fluids. I believe she asked us an IV fluid question. Honestly, you probably should know this anyways. Even though it feels like you forget it every like 5 minutes, so I totally get it. So isotonic, this is kind of neutral, right? So their water is going in and out at the same time for your cells and within that extracellular space. So the water's coming in, out, kind of just neutral, right? So what's the most common IV fluid we give to our patients? That's going to be NS, right? 0.9% NS. That also includes ringer solution and lactated ringers. So really, but what she's going to say is like normal saline, right? So, and she's going to say 0.9. For hypotonic state, that means that it has less osmolality, so less concentration than the blood. So what that basically means is that the water is being pulled from the blood vessels into the cell. So from the extracellular space now into the cell when you're giving these IV fluids. But basically that can cause, because you're pulling in all of the extracellular fluid now into the cell, which is intracellular, which we know makes up more of our body weight, right? Because there's millions and millions of cells. That can cause your cells to keep growing, and then burst. So that is something you want to be aware of. But really what you have to know is for hypotonic fluids, you're going to be talking about any type of fluid that's below the 0.9%, right? It does start with D5W, so it does start isotonic and then it gets hypotonic. But really, I think more of the one she asks is like 0.5%. 0.45% saline, 0.33% saline, 0.225% saline, which is all less than 9, right? So you have a neutral one, which is your 0.9 saline. The hypotonic, that's pulling in fluid to go into the cell. Those are all less than the 9%. I feel like that's pretty easy to remember. And then for the hypertonic, that's going to be any that's above 0.9%, right? So just know that it's going to be any above 0.9%. So if you see like 14%, I don't think it has that, but if you see that, it's going to be that. If you see anything above the D5W, that as well. And then the other ones include D5NS, D5LR. So just kind of memorize those, kind of understand that. And then with hypertonic, we're just talking about a higher osmolality, a higher concentration than the blood. So what's going to happen, we're going from osmosis, right? The water is going to be pulled out of the cells into the vessel. So that's going to cause all that water to come out, and now your cells are going to be shrinking. So basically that can lead to also some more edema because all of that fluid in your cells is now coming out, right? Because now it's going to the extracellular space, which is more, when we're talking about edema, we're talking about that extracellular space, like your interstitial fluids and all of that. So just know your fluids. And for the rest of the stuff, I mean, we'll talk about that later, but know your fluids, know the raw system, be able to tell me what signs and symptoms are, your ABGs, what can cause it, the osmotic pressures, filtrations, that type of stuff you need to know. So just go over that, the raw system. And then I think that's pretty much it for that. I feel like that's what the questions that she asked. But other than that, I think that's all for today. But other than that, I think you guys are all good to go. But one more quick thing, just because I have to do this every single time and I feel kind of guilty for making you guys do this. If you guys can just fill out the tutor survey, that would be perfect. And just go ahead and put the time. I'll stay in here till 12. If you guys can just put 10 a.m. to 12 p.m. If you guys have any questions or you want me to go over something, I'll just stay here till 12 anyways. So just go ahead and fill that form out for me and I get paid essentially, which is really cool. But other than that, yeah, I hope the exam went well. You feel free to rant to me for these next 15 minutes if you guys don't have questions. I can only imagine. I heard that it was a little bit difficult, and I know the first exam is really difficult, but don't let it define you, because you'll be able to even out your grade. And keep in mind too, everybody passed hardening and everybody passed justice. So, that doesn't mean don't study, but you'll be okay. But let me go ahead and stop the recording as well.